heard. You're muted.
Nick, you are now the co-host, by the way. So if you could click the admit button when people join, so that I don't get distracted, and then start welcoming people in the chat, that would be fantastic. Thank you so much. Cool. I already welcomed Jonathan and Regina, so there's a few other folks on the call now. Let's give it maybe 4 more minutes so that we have enough people. Welcome, everyone. We're going to give it just a couple more minutes to ensure that we have enough folks for attendance to get started. Thank you for being here. If you wouldn't mind, please sharing what hospital you're joining us from in the chat, that would be awesome. We try to keep attendance so that we know how big of a reach we have each month and whether things are changing in terms of who's aware that this exists and that sort of thing. So thank you again. Hi guys, welcome. Good to see some familiar names. We're going to get started in about 2 minutes just to give more people time to show up. Thank you so much for being here. Nick, do you want me to leave the sound on when people join? It's a little distracting for me, but totally up to you. You're okay with it off? Okay. All right. Well, I think we're going to go ahead and get started. It looks like we've got plenty of people here. Thank you so much for being here. My name is Jess Pelletier, and this is Nick Maxwell. And we are from Techies Without Borders. We're a nonprofit that delivers free continuing education. It looks like we've got a lot of folks from Uganda today, so I'm sure some of you saw this invitation in the ECHO group chats, which is fantastic. I am going to share my PowerPoint slides with you guys. And without further ado, we'll get started. So this is just an outline of what our plan is for the day. We'll do a bit of an introduction on what is CMES, and then we'll dive into a case. We'll go through what shock is, how to identify the cause, how to manage it, and then how to kind of assess response to treatments and therapies, which I think is one of the most important parts for physicians and for nurses. Again, if you haven't shared in the chat where you're joining us from, please do so. So what is Techies Without Borders? First is the question that I'm sure some of you have who are new to this group. We're a nonprofit that's dedicated to delivering free, high-quality continuing education with a focus on emergency care. We work with 19 low and middle income countries to help bring free education resources. And one of the biggest ways we do that is something called the Continuing Medical Education Solutions Program, also known as CMES. If you're interested, you can learn more at the QR code. We have a podcast that quickly describes what we do, but essentially we use technology solutions to help deliver free education. Some of you work at hospital sites that have these technology solutions. Basically, they let you download PDF and podcast files on medical topics without needing to use data or internet. But we also do a lot of free education that does not require you to have one of our technology solutions. And the Journal Club is one of the ways we do that. If you are in one of the ECHO group chats, you've seen that we also collaborate with Seed Global Health, and we help write summaries of all the ECHO sessions. So there's a lot of different things we do, but we're really thrilled to have you here for Journal Club. All right, so this is going to be an active participation sort of thing. So you can feel free to chime in the chat, or you can speak aloud when I ask questions. We love engagement. We love people to speak up. So we'll start with a case. You have a 42-year-old male with a history of pulmonary hypertension coming in for shortness of breath. He takes bosentan, which is an agent that helps dilate the pulmonary vessels, but he's not on oxygen at home. Currently, his vital signs are notable for hypotension, tachycardia, tachypnea, and hypoxia. On exam, he's speaking in short sentences, and he actually has jugular venous distension. His lungs are clear, his heart is tachycardic with regular rhythm, and his belly is soft and non-tender, but you do notice some hepatomegaly, and there's trace peripheral edema. What would be your next steps at this point? Anyone can feel free to chime in out loud or in the chat on what you would do with this really sick patient. So I know my first approach would be ABC, so airway, breathing. Oh, speak up, sorry. Go ahead. Someone's
after the ABCDEs, I think US is a good idea. After the ABCD.
Good. So talk me through how you would approach the ABCs for this patient, Jonathan. It sounds like he's speaking in short sentences, so we know his airway is intact, but breathing is definitely compromised in this scenario. And so I would put supplemental oxygen on this patient. I'd be really careful, given his history of pulmonary hypertension, about things like non-invasive positive pressure ventilation, since that will increase the pressure in his chest and he may actually get sicker. It's hard to say for certain. So maybe starting with nasal cannula, and if that doesn't work, to raise his oxygen saturation and decrease his work of breathing, I might put him on a non-rebreather at 15 liters. In terms of circulation, that looks like it's definitely compromised for this patient. So how would people address the circulation issue, the hypotension and the tachycardia? I know I would probably give some small fluid boluses, because this patient has a history of pulmonary hypertension, which means that he may have a hard time with large volumes of fluid. He does have some signs of congestive heart failure going on. He's got hepatomegaly, probably from hepatic congestion, and he's got some trace peripheral edema. So I would try only small fluid boluses and probably move to pressors pretty quickly. But before moving to pressors, I would definitely get my ultrasound out and take a look and see what's going on with him. Can anyone tell me what looks wrong on this ultrasound? There's something in particular that I'm concerned about here.
The right ventricle.
Yeah, so the right ventricle is huge. And then there's also something swimming around in here in the right ventricle.
What?
Yeah, there's a clot. Thank you. Yeah, so this patient has a big clot in their heart. So they actually have a pulmonary embolism as their underlying cause of shock. In light of that, given that the patient's in shock, what might we want to do for this patient's shock? So we know they have a pulmonary embolism. Their heart is stressed and strained. and they have a big clot in their right ventricle. What could be some options to treat this patient?
Anticoagulate and then give some support, inotropic support, epinephrine, dobutamine, give an inoconstrictor and then an inodilator, and then give anticoagulation.
Yeah, I agree with all those things. The one thing I might consider starting before the anticoagulation would be a thrombolytic for this patient because they're in shock, right? So they have a massive pulmonary embolism by definition. So if you have thrombolytics available at your site, something like tenecteplase or alteplase, something like that, it might be wise to try that. Usually the dose is around 100 milligrams for a patient in shock. You can do 50 milligrams as well. For alteplase. We won't get into dosing here, but yeah, thrombolytic followed by anticoagulation for this patient. And then I agree, vasopressor support, inotropes if needed, because it doesn't look like they have very good cardiac squeeze. All right, so now let's say that you gave the thrombolytic and you start IV heparin, so you give an anticoagulant, and then the patient becomes hypotensive again. So they were stable for a little while, but they get sick again. And now they're hypotensive, they're vomiting, and they feel like their throat is closing. What might be your approach to shock at this point?
To do a definitive airway and then some more support.
Yeah, do you know specifically what type of support might we want for this patient who's showing some signs and symptoms of anaphylaxis? Yeah, Ruth, thank you. What drug?
Steroids.
We're going to give epinephrine for this patient, right? So their signs and symptoms.
Anaphylaxis.
Yeah, good. So I would probably start with intramuscular epinephrine because that tends to get absorbed faster than subcutaneous. And if you're needing more than 3 doses, that's where I would consider starting an epinephrine infusion if you have a good intravenous access or intraosseous access. So if you have IV or IO, you could certainly consider starting an epi drip for this patient. I think I would probably, I agree with you, Regina, consider securing the airway, but I would give the epi first. Reason being, if we go to, essentially, if we go to intubate this patient while he's still hypotensive and an anaphylactic shock, he may go into cardiac arrest because he's so unstable. So I would probably consider getting his blood pressure under control first, obviously suctioning if the vomiting is compromising his airway. And then if he's not stabilizing with the epinephrine, then yeah, either way, he'll definitely need to be intubated. All right, your patient recovers and gets weaned off of vasopressors. He's transitioned to warfarin and ultimately discharged home. So this was just sort of a deep dive into shock to give everyone a little sense of what we're going to be talking about today. We went through 2 types of shock here. We discussed obstructive shock and anaphylactic shock, but we're going to go through all of the different kinds of shock today. All right, so first of all, what is shock? Now, shock is a life-threatening condition defined by persistent inadequate delivery of oxygen and nutrients to meet cellular metabolic demands. And that's often from insufficient perfusion. And one thing I want folks to remember today is that shock does not necessarily equal hypotension, right? So a patient may not be hypotensive initially when they present with shock. And so we need to be able to recognize these other signs and symptoms of shock that can present even earlier than low blood pressure so that we get on top of the situation early and gain control. So things like decreased mental status or cyanosis. If someone's hypotensive, then it's a little more obvious if they're tachycardic, those sort of things. So basically vital sign derangements. But early signs that you may also see can be things like oliguria, so making less urine than usual, or if you have weak or bounding peripheral pulses. I think capillary refill is a very important one because it's so easy for us to recognize and it's so easy to do, but I think we forget to do it a lot of the time. Now, our ability to detect pulses for folks in cardiac arrest is not great, but while someone still has enough blood pressure to produce good pulses, then our ability to palpate them is a bit better. And so checking those pulses to see if they're bounding or weak can help us differentiate what kind of shock might be going on. One thing I want to touch on here is called the shock index. If you're familiar with that, please feel free to chime in the chat. I'd love to hear whether people are using this in practice, but it's been found to be more useful than heart rate or blood pressure alone to diagnose shock. So you divide the heart rate by the blood pressure. So for example, if my heart rate is 120 and my blood pressure is 60, then my shock index is 2, which is not good. So normal is 0.5 to 0.7. And more than 0.8 in medical patients and more than 1 in trauma patients is worrisome or concerning for shock. We're not going to cover traumatic causes of shock like bleeding today in detail. That would be a whole separate lecture. We're going to talk about medical causes of shock today. But just keep in mind that the higher your shock index is, the worst. So
systolic blood pressure, please.
What was that, Regina?
That's a systolic blood pressure.
Yes, ma'am. Yeah. 120. If that was my systolic blood pressure, I would divide that, or sorry. But yes, systolic blood pressure. So if my heart rate's 120 and my systolic blood pressure is 60, then I would just divide the heart rate by the blood pressure and I would get 2 for that patient's shock index, which is very bad. Great question. So shock is pretty common. This is seen on a pretty much daily basis in a lot of our emergency departments. And the 30-day mortality is huge. So 30% of these patients die by 1 month. And the mortality from hemorrhagic shock may be even worse. But again, we're not going to talk about traumatic hemorrhagic shock today. Overall mortality range is up to 50%. And then we need to realize that morbidity and mortality are higher in limited resource settings. And that applies whether you're in an LMIC or if you're in rural United States. If you are far from healthcare or far from a facility that's capable of taking care of your shock, then you're at much higher risk for dying from this condition. So people who are at the highest risk are the ones that do not present with low blood pressure. Cryptic shock patients. So these are the people with no hypotension. And that's why it's so important that we're evaluating those other things we discussed earlier. So changes in mental status, changes in urine output, capillary refill. And then who's at higher risk depends on the type of shock. But in general, cryptic shock patients are going to be your old people, your very young people, and the immunocompromised. So people with autoimmune conditions or people on chemotherapy, that sort of thing. Now, how do we actually figure out which type of shock someone is suffering from? That's the next question here. So remember that common things are common. And so septic shock is going to be the most common cause of shock overall. It doesn't matter whether you're practicing in the United States or the Gambia, Uganda, Nigeria, septic shock is most common. And hypovolemic shock can overlap with that a lot. So we'll talk about that in a little bit here. So I want to go through the prevalence of different types of shock so we can get a sense of how common they are. But things like septic shock are going to be that biggest category. And then things like hypovolemic shock. So for example, you have a ton of diarrhea because you got cholera, which is pretty relevant right now in East Africa for some of you, since there have been some cholera outbreaks. Things like that, hypovolemic shock are the next most common cause. And bleeding falls into the hypovolemic shock category as well. So if I'm having an upper GI bleed or a lower GI bleed, or we're not going to get into traumatic hypovolemic shock today, but if I'm bleeding from a trauma, which I know is very common in some of your settings, that's also a thing that can be quite common. Cardiogenic shock is the next most common. And then the less common ones, distributive shock that's not septic. So things like anaphylactic shock, and we'll get into that later. And then obstructive shock is the least common. So something like a massive pulmonary embolism or tension pneumothorax. All right, so then taking the history. Again, septic shock is the most common, so we need to make sure we know whether the patient's been having infectious symptoms. Have they had a fever, body aches, flu-like symptoms? Have they had infectious exposures? Are they immune compromised in some way? Are they on chronic steroids or chemotherapy? Do they have an autoimmune condition? Do they have uncontrolled HIV or AIDS? And then cardiovascular conditions. So do they have underlying heart failure or other heart problems? And then relevant to a lot of us would be bites, stings, or exposures. I know in the news recently, some places that had antivenom for snake bites are starting to close because of the loss of funding to USAID. And so that's going to be something we need to think about probably a little more often than we did before. If people can't get access to antitoxins or antivenoms, that may be more of a problem than it used to be. All right, so physical exam for distributive shock. We'll start with that first. So this is going to be folks with septic shock. There are other distributive shock forms as well, but they should have brisk capillary refill, meaning you squeeze their finger and the blood comes back right away. Their extremities are typically warm as well. So this is a warm shock when we think about distributive shock. Cardiogenic shock is typically more of a cold shock. So they will have cool extremities with delayed capillary refill, and then they may have other signs of heart failure, like our initial patient did, who was suffering from a massive pulmonary embolism. So they had obstructive shock that was leading to heart failure. But cardiogenic shock, you'll look for some of the same things. So jugular venous distension, peripheral edema, they may have rales or crackles when you auscultate their lungs. And you might feel hepatosplenomegaly because fluid backs up from the heart and lungs and it ends up in those intra-abdominal organs and causes some distension or congestion there. Obstructive shock, like our initial case. So these are going to be the people in cold shock, but who also have some other weird finding when you auscultate. So either muffled heart sounds or decreased breath sounds on one side, because we're usually thinking about number one would be a cardiac tamponade. So they would have muffled heart sounds, or we're thinking about a tension pneumothorax, and those people should have decreased breath sounds on one side. There's other causes of obstructive shock that we'll go through in a little bit, but they may or may not have murmur, rub, or gallop as well when you listen. So again, warm shock, distributive. Cold shock is going to be obstructive or cardiogenic. Okay, so for the physical exam for distributive or hypovolemic shock, you need to think about the things you need to look for. So if someone's had a snake bite, go look at the snake bite area. If they've had a bee sting, go look at the bee sting area. If they have been exposed to some sort of drug or toxin, asking about things like endocrine history. So hyperthyroidism or thyroid storm can present with a distributive shock as well. So checking a thyroid exam if that's relevant for your particular patient. Things like toxic shock syndrome. So do they have like a diffuse red rash that's that may be blanching? And then thinking about severe dehydration, asking them about whether they've been eating and drinking, looking at their mucous membranes, checking for skin tenting. Neurogenic shock should be a little more obvious. So these are usually people who've had a spinal cord injury of some kind. So they're typically coming in with trauma, though that's not always the case. I suppose you could have a mass or something like that that impinges on the spinal cord, but that's not usually an acute presentation to an emergency setting. All right, we've gone through the physical exam. So now let's talk about the management for shock. And please keep in mind that not all of the vasopressors and inotropes I'm going to talk about here are available in all settings. And so I would love for people to chime in the chat as we go along and say, you know, this is not something I have available, but this is what we do where I work. So this is meant to be a bi-directional learning experience and be conversational. Please do chime in. So first of all, for management, we do A before B and B before C, like Jonathan was saying earlier. So airway before breathing, breathing before circulation. If you don't have an airway, meaning like you're not speaking or maintaining your ability to breathe, then you're going to be dead faster than from anything else. And so airway comes first. So if a patient is not able to speak, or they've got very altered mentation, then we should be concerned about their ability to protect that airway. And we need to consider whether they need to be intubated. This is tricky though, because intubating a patient who is in shock can also lead to them going into cardiac arrest and dying very quickly. And so there's a fine balance here. I would say protect the airway as best as you can for the shock patient, meaning suctioning if they're vomiting, providing them with supplemental respirations if they're not doing a good enough job on their own. But I would wait to intubate until you've tried to stabilize their shock a little bit so that they don't go into cardiac arrest. There's also going to be situations that many of you are in where you cannot intubate. I know someone here is from Ocean Clinic, a couple of you are. You guys are not going to be able to intubate somebody at an outpatient clinic. And so you have to do the best you can with the resources you have. So if able, getting large bore IVs is great for the patient in shock. If you can't do that, intraosseous access is a fantastic option. I would love to hear in the chat how many of you have access to intraosseous access. I know that a lot of the academic centers have that, but you may not have it in some of the smaller clinics. And then if you do have access to continuous cardiac monitoring, like a telemetry monitor, that's a great thing for the shock patient. I've been to a lot of your hospital sites, and I know many of you do not have that available. And so you do the best you can with what you have. If you don't have telemetry monitoring, then checking pulses frequently is going to be important. Continuously checking capillary refill, mental status, things that you can check at the bedside. All right, so then the actual specific management is going to vary depending on the source of shock, and we'll go through those. But first, I want to do a quick overview of vasopressors. Again, you may not have all of these. I don't have all of these in my setting, but I think this is a beautiful image to give you an idea of what the specific role is of each of these drugs. The first line drug for almost all types of shock is going to be norepinephrine, and there are exceptions to that. But norepinephrine is nice because it's fairly neutral in terms of its impact on the heart and on the lungs. And what these images mean is that norepinephrine does not typically cause cardiac rhythm problems. It doesn't irritate the heart, and then it doesn't constrict the pulmonary vessels. And so that's why there's sort of these neutral faces next to the EKG picture and the heart, or the lung picture rather. If we compare that with something like epinephrine, epinephrine tends to cause cardiac rhythm issues. It's very irritating to the heart, but it's really great for the lungs. Realize, sometimes we give epinephrine for severe asthma or COPD exacerbations because it opens up and decreases bronchospasm and things like that. And so these faces are meant to show you what the effects are of each drug on a specific thing. So we'll go through a lot of these drugs today. And again, we are not all going to have access to all of these drugs, but if you do have access, then it's great to know how they work and what they're ideal for. Let's talk about distributive shock first, and we'll start with septic shock. Again, the most common form of shock is going to be septic shock. Your initial target is probably going to be somewhere around 30 mLs per kilogram of balanced crystalloids in the first 60 minutes. And this is quite controversial, meaning you can't just say that there's one specific volume amount that's ideal for all patients. So for example, if I have someone with baseline heart failure who's coming in septic shock, I probably do not want to give them 30 milliliters per kilogram. That is a lot of volume. That's like 2 liters of fluid for a lot of people. And that person's going to drown, right? They're going to get pulmonary edema. And so I need to very carefully assess whether a large volume of fluids is needed or not. For a young, healthy patient coming in septic shock who has no baseline heart failure, then 30 milliliters per kilogram is quite reasonable. And if they have overlapping hypovolemic shock, meaning that they've been having diarrhea and vomiting, and they have a lot of volume losses, they've got dry mucous membranes or skin tinting, then they may need even more than 30 milliliters per kilogram. And so it's very important to continuously reassess your patient and think about what baseline conditions they have. Where there's less controversy in the literature is that balanced crystalloids are always better if you're giving large volumes of fluids, meaning that something like lactated ringers or Plasmolite or Normasol, if you have any of those available, is probably better than normal saline for patients who are going to need large volume resuscitation. And the reason is that normal saline, it has a lot of salt in it, and it's not as similar to someone's actual blood as something like lactated ringers. So lactated ringers is more neutral. It's more similar in its chemical structure to someone's own blood products. And so I would probably consider giving something like lactated ringers for large volume resuscitation. Also realize if your patient's bleeding, please replace blood with blood if you have blood available. Don't give crystalloid fluids to someone in hypovolemic shock from blood loss, because it will end up diluting the blood, and then it actually causes them to have problems coagulating their blood. So that's a major issue. All right, so that's IV fluids. I would love to hear in the chat, please chime in, what types of balanced crystalloids people have access to, if they have balanced crystalloids at all. And then remember too, if you do not have access to IV supplies, let's say you work middle of nowhere and you've got a septic shock patient who is protecting their airway, having them drink, oral rehydration solution is better than nothing. If you cannot get an IV or an IO, having them drink some fluids might be better than doing nothing at all. All right. And then another key staple of management for your septic shock patient is obviously going to be early broad spectrum antibiotics. And what broad spectrum means is very different depending on where we work. I know in Uganda, ceftriaxone is considered to be broad spectrum. Where Nick and I work, we often give something like cefepime or piperacillin tazobactam plus vancomycin for broad spectrum because we have a lot of drug resistant organisms. And so oh, thanks, Agnes. She just commented in the chat that they have lactated ringers, which is fantastic. I think lactated ringers is the way to go most of the time compared to normal saline. I'm hoping that normal saline someday just goes away because it's not very physiologic, but for now, we'll have to deal with it. Coming back to management with antibiotics, like I said, broad spectrum, whatever that means in your setting. So whatever is recommended by your government, recommended by, your guidelines, and then try to obtain blood cultures or other relevant cultures first before you give antibiotics. So if someone has signs and symptoms of a urinary tract infection, try to get that urine sample before the antibiotics. If you think that they have meningitis, then you should try and get an LP. But I will say getting a lumbar puncture before someone crashes who's in septic shock is very unrealistic. And so if someone is truly in septic shock, give the antibiotics early. I don't care if you got the cultures or not. Your patient's life is more important. And then in many of your settings, antimalarials should also be considered since severe malaria can present very similarly to septic shock. Okay, and then for vasopressor management, like I said, norepinephrine is usually first line for most types of shock, and that's very true here in the setting of septic shock. This is also known as noradrenaline, so I do apologize that this is the American version, but noradrenaline is the same drug as what we're talking about. All right, and then one thing to note is that you can give noradrenaline via a peripheral IV for up to 24 hours quite safely. So a lot of us will not have the ability to get a central venous access in our settings. And so just remember that you can give this via a peripheral IV as long as it's a pretty good IV. And intraosseous access is great. You can give everything through an IO just like you can through an IV. For second line agents, you can consider adding on things like vasopressin, epinephrine, or phenylephrine for your septic shock patient if you have those available to you. But you need to think about the patient you have in front of you, right? So if I have a patient in septic shock who also has heart failure, so they are at high risk for going into funny heart rhythms, things like AFib and stuff like that, I'm probably not going to give them epinephrine as their second line agent. But if this is someone who's young and healthy and they have good cardiac squeeze on my bedside ultrasound, then I might consider something like epinephrine in that case. All right, so like we've talked about distributive shock, specifically septic shock here. Does anyone have questions about that before we move on to cardiogenic shock?
Yes, I do. So it's about the norepinephrine. I know you said you won't talk about the dose, please. I'm sorry. But how often, what am I going to assess? Because what I'm taught is after I use the INO constrictors like norepinephrine for some time, I should bring in the INO dilators. So I didn't hear you mention that. So I just wondered, and when do I stop and reconsider, etc.? How often do I, check and all of that? Yeah.
Great question. Regarding the rechecking, I think some of this is going to come down to your individual patient. But I would say when I have a patient on vasopressors, I'm trying to check them like every 15 to 20 minutes. And my nurses are probably checking even more frequently. And this is going to depend on how many patients you're carrying as well, Regina. If you have like 1 million patients at that time, you're not going to be able to be in there that quickly. So if you have a medical student or a nursing student or somebody else that you can have check on them, then that works. Regarding INO dilators and stuff like that, are you referring to things like milrinone and dobutamine and that sort of stuff?
Actually, it's dobutamine. I have more experience with norepinephrine and dobutamine.
Okay.
So it constricts forever.
Yeah. And so honestly, a lot of guidelines now are recommending for septic shock specifically that we just stick with things like vasopressors. If you think that your patient needs a little bit more squeeze because their heart does not look like it's squeezing well on your bedside ultrasound, or if you just, your clinical assessment, if you don't have ultrasound, if you think they don't have good cardiac squeeze, maybe they've got a little bit of baseline heart failure, then I think it's a tough choice, but it will depend on what you have available. Epinephrine is a great choice because it does have some inotropic effects as well as being a vasopressor. So in someone who has no baseline risk for heart rhythm issues, so they don't have a risk for a cardiac arrhythmia that I know of, then I would choose epinephrine for that person. If you're dealing with a septic shock patient who also has heart failure, Regina, then I agree with you. Adding on something like an inotrope like dobutamine would be a great option. So it's going to depend on what baseline problems the person has. I hope that answers your question.
Can I ask one more? Then
Yeah.
at what points do I bring in the mechanical support? Because I don't know.
Mechanical support. So are you referring to things like balloon pump and things like that, or ECMO?
ECMO, impeller, yeah, stuff like that.
Well, certainly, I'm glad to hear that you have that stuff in your setting. I know that's hard to get actually in my setting, and a lot of the folks on this call don't have access to that. But I would say I'm considering adding on something like mechanical support, like an Impella or other options like ECMO if someone's on like 4 pressors. So I'm going to try 4 pressors plus or minus inotrope. So this is the person who's maximized medical therapy and they're still not doing well. And that's the point where I'm reaching for mechanical support because it requires a lot of resources, right? You got to bring in a fancy consultant who can do the procedure to put whatever that option is into the patient. And you need to have an ICU bed, which some of us here don't have access to. And so I think it's going to depend on your setting, but at least where I work, I'm probably running at least 4 medications through central lines before I'm thinking about mechanical support.
Thank you.
Yeah, thank you. Such great questions. All right, cardiogenic shock, moving on here. So these are folks where they are going to have very tenuous abilities to tolerate fluids. And so I would say if you've got a cardiogenic shock patient in front of you and they look kind of dry, so they tell you they've also been having vomiting and diarrhea, things like that, you might want to give a little bit more fluids. But there are some people in cardiogenic shock who can't tolerate fluids at all. They just look like they're swimming in fluid, like, they have anasarca. Their whole body is edematous. They've got rails 3/4 up the lungs. That's probably not someone that I want to give fluids to because it's just going to leak into their pulmonary spaces. And so those are people where I might not give fluids at all. But if I do give fluids, because I think the person can tolerate it, I'll give small boluses. Instead of 30 milliliters per kilogram, I'm considering things like 5 milliliters per kilogram. And then I'm going to reassess every 5 to 10 minutes and see how they're tolerating it. And if they don't respond to fluids, they still look shocky. So they still have delayed capillary refill. They look really ill. They're confused, things like that. Then I'm considering moving to pressors early. And norepinephrine is another good choice here because it will not stimulate cardiac rhythm problems and it's pretty neutral for the lungs. And then like Regina was just asking a moment ago, this is the person where I may reach for an inotrope. So this is in my setting going to depend a little bit on what my bedside ultrasound looks like. And if you don't have ultrasound, some of this is just going to be clinical judgment. So that someone has a history of heart failure, you might want to consider an inotrope early if this is available to you. I know where I work, I do not have levosimendan, and we really don't give milrinone in my setting because it's a little bit, it takes longer to work, honestly, than dobutamine. So dobutamine would probably be my inotrope of choice to help increase cardiac squeeze if I'm worried about that. All right, so cardiogenic shock secondary to a dysrhythmia. So let's say you have someone coming in cardiogenic shock, but you think it's being driven by the fact that they are in rapid AFib, or they're in supraventricular tachycardia like SVT, or they're in VTAC, then I'm going to use electricity, not medications. And I would love to hear in the chat who has access to something like things like an AED, a defibrillator, that sort of thing. So feel free to chime in because I know some of you do not have that where you work. I think a couple of folks from Ocean Clinic are here. I know that we're bringing you an AED this summer, which I'm excited about, but you don't have one right now. And so you have to work with what you have. If you do not have an AED, then you got to do what you got to do, meaning that you might need to give them some fluids. Maybe you need to give them some pressors and you need to get them to a higher level of care. But if a rhythm problem is a thing that is driving the shock, then you need to use electricity to fix it. Any questions about cardiogenic shock before we move to obstructive shock?
I think to Regina's point too, cardiogenic shock is one of the ones where I often think about mechanical support. Those are the ones that sometimes can really benefit from ECMO and stuff like that, or Impellas and whatnot. Whereas like I think a lot of times we talk about septic or shock as like a category, but like it's so vastly different. So like I would rarely ever put somebody in septic shock on ECMO. Because it depends on what the underlying problem is, but cardiogenic shock would be a really good one.
Yeah, and I agree with Nick. I've honestly maybe seen someone in septic shock end up on ECMO only 1 or 2 times, but cardiogenic shock, that's much more common, that you may need some sort of mechanical support because their heart simply can't do the work. The challenge becomes the question that Regina asked earlier, where you have someone in both septic and cardiogenic shock, or someone with septic shock who has baseline heart failure. Those people are more likely to end up with mechanical support where it's available, because that's just a hot mess. Lots of great questions here. Okay, moving to obstructive shock. So you need to fix the underlying cause for these people where it can be fixed. And there are some causes of obstructive shock that you and I are not going to be able to fix in the clinic or in the emergency setting, and we'll talk about that. Who can tell me what's going on with this poor patient? This is a very scary cause of obstructive shock.
Pneumothorax?
Yeah, tension pneumothorax specifically. So you guys can probably see that there are lung markings on the left side for this patient. There are no lung markings over here. It is way too black on this right lung space. And then you also see that the mediastinum, so all the stuff in the middle of the chest, is being pushed over to the left side. And that's because there is more and more pressure building up in the space around the lung on the right side. It's full of air over there. This is the poor lung collapsed. This is all just air, and it's shoving everything over. And this is a horrifying, dangerous situation. I would say that in my setting, at least where I have access to chest tubes, that the first line treatment is going to be decompression with my finger. So I'm going to clean the skin really fast and make a hole and stick my finger in to let that air out, because then I can just put a chest tube in. If you work somewhere that doesn't have chest tubes, then you're probably not going to want to do a finger thoracostomy like that, and you may still be using needle decompression. So for needle decompression, the guidelines used to say second intercostal space in the midclavicular line, which would be right here. Can you guys see my mouse, by the way? Nick, can you see my mouse?
We can.
Yeah. Okay, perfect. So it used to be going right here. The problem with that is that you have subclavian vessels right there. And so you can hit big vessels, which is one problem. And the second problem is if your patient's obese, you may not actually get through all of that fat on the chest wall to get down to where you need to be. So the new guidelines recommend 4th to 5th intercostal space in the mid-axillary line, which is more like where we're putting a chest tube for needle decompression. And something like an 18 gauge is not going to work. It needs to be a big needle. So we're talking like a 14 gauge needle. I know when I was a resident, I used to carry that around in my pocket, but never ended up using it. And at some point they expire. So you really can't walk around with those because it's a precious resource. But the biggest needle you have would be the goal here, to decompress a tension pneumothorax. And remember, they should have no lung sounds on one side if they have a tension pneumothorax. But otherwise, this can look very similar to obstructive shock from something like tamponade. They're going to have jugular venous distension. They may have signs of heart failure. And so they can look quite similar. So again, the definitive treatment here is going to be a chest tube. I know for those of you who are members of ECHO in Uganda, at one point people were asking, what do I do if I don't have a chest tube? If someone's actually this sick and showing up to your critical access rural setting, you need to do this sterile. Please keep that in mind, but you can technically use a large Foley catheter and use that as a chest tube if you have nothing else and the person's going to die. So it's better to do something rather than nothing. And so if you don't have a large bore needle and this person's about to die from a tension pneumothorax, you can make a cut in that 4th to 5th intercostal space in the mid-axillary line under sterile conditions, and you can stick the largest Foley catheter you have in there because that's better than nothing. You do need to connect that to something that's vacuum sealed so that you don't make their condition worse. And so I would not do this at all. Like, don't try to put in anything like a tube of any kind if you don't have a vacuum sealed object, because otherwise air is just going to keep going through that tube and make the situation worse. I hope that makes sense. So the next example of obstructive shock, can anyone tell me what looks wrong here? Well, obviously it has the words, but I want you to look at the pictures and tell me why this looks concerning. I'm going to try and get it to jump ahead to the actual video so you can tell me in words what looks scary here on this video. And this is in nice slow motion so you can get a sense of what the actual problem is.
Diastolic collapse of the RV.
Yeah, look at that. So this poor right ventricle is completely collapsing because of the pressure that's inside of that sac around the heart. And that's a problem. So if you have access to ultrasound, then yay, that's great because you can make this diagnosis in like a second. But if you don't have access to ultrasound, then checking to see if the patient has muffled heart sounds or anything similar to that. And then the definitive treatment is going to be a pericardial window. So meaning someone fancy like a surgeon of some kind needs to cut a little hole in the pericardial sac to drain the fluid. But a temporizing measure would be taking fluid off of the sac around the heart. So there are two approaches to do this, and we're not going to go into detail. One of them is subxiphoid, meaning you go underneath the rib cage and point toward the heart. The problem with that one is you're probably going to do a liver biopsy along the way. And then the other option is going to the left side of the sternum, so the parasternal approach. Two problems with that one. Number one, you can cause a pneumothorax, so you could pop the lung. And then number two, you can cause bleeding from the artery that runs on the underside of the sternum on the left, the internal mammary artery. So there's a few big issues with this. So only someone who's highly qualified and trained to do this should be doing this procedure because it's rather scary. Other causes of obstructive shock to know about. So the initial case we went through earlier, right? So a massive pulmonary embolism. We don't see this very often. It's pretty rare, to be honest, that you get obstructive shock from a PE. But if that's the case, then the treatment is going to be thrombolytics. Severe pulmonary hypertension is another one. Oh, Ruth, actually, before we move on, do you want to chime in on the apical approach? Because I've actually never learned that for doing a pericardiocentesis. I've only learned the subxiphoid and the parasternal approach. Is anyone else familiar with the apical approach? Feel free to chime in the chat, Ruth, with where you go for that, because I'm actually not familiar, so I'm learning things here. Coming back to the person with a massive pulmonary embolism. So if someone's truly an obstructive shock from a massive PE, then you're going to see dilation of the right ventricle, as well as this floppy movement of the tip of the right ventricle on ultrasound, which is called McConnell's sign. And you may actually see clot in the right ventricle like we did for our initial patient. Those patients you should be considering thrombolytics for, and just realize you probably want to wait to start the heparin for at least an hour after you give thrombolytics because you don't want to increase their bleeding risk more than you have to.
Can I just see the slide before that one?
Yeah.
Before the CTP. Okay. Thank you.
Yeah, absolutely. These other ones are pretty uncommon. I am curious how often you guys see constrictive or restrictive processes like constrictive pericarditis or restrictive cardiomyopathy. Those are often caused by tuberculosis, so I don't see them much in my setting. I know Nick and I see severe pulmonary hypertension causing shock. Not infrequently here, mainly because a lot of people run around with untreated obstructive sleep apnea in this country. And that's mainly because they're very obese. And so this is unfortunately quite common where we work, very sad. But in any event, severe pulmonary hypertension, these people can get volume overloaded very quickly. And so only small fluid boluses are wise. And then I would talk to a pulmonologist, like their lung doctor, early if possible, because these people are probably going to need pulmonary vasodilators while you do vasopressor support. We won't get into deep detail on that because it's not as common in most settings. Norepinephrine is still first line for your vasopressor in pulmonary hypertension, but you need to consider also giving a pulmonary vasodilator in conjunction with talking to someone like a pulmonologist. If you don't have a pulmonologist, then small doses of inhaled nitroglycerin are an option that's available in a lot of settings. So you can literally nebulize it the way you would nebulize albuterol. We won't get into dosing on that today. And then vasopressin would be a second line for these people if they're in shock. Again, I won't get into this in too much detail, but other than inhaled nitroglycerin, you can also nebulize milrinone if you have it available to help dilate the pulmonary arteries. How often are folks seeing constrictive pericarditis and restrictive cardiomyopathy causing obstructive shock? Because again, Nick and I don't see that very often, but I know tuberculosis is more common in some of your settings than in ours. So I'd love to hear in the chat if people see this frequently, infrequently. I genuinely don't know, but we're not going to be able to fix them in the ER, so only temporize their shock. I would probably not give large volumes of fluid for these people because they can't really expand their volume very much if the heart is in an enclosed space. So these would be people I'm jumping to vasopressors early as opposed to lots of fluids. Again, we can only temporize them. And then if they're in tamponade, then you treat it like obstructive shock and you're going to do a pericardiocentesis. All right, moving on from obstructive shock to distributive shock. Does anyone have questions about obstructive shock before we move on? All right. So the key here is going to be fixing the underlying cause if we've got somebody in another form of distributive shock, something other than septic shock. So for anaphylaxis, the only true treatment is epinephrine. There's a lot of data out there to say that unfortunately, we often choose to mask anaphylaxis by giving things like steroids and giving antihistamines, but those are not going to fix the underlying problem. Only epinephrine can do that, especially if the patient is in shock. And so antihistamines can be helpful for symptom relief, but please do not use these to treat anaphylaxis. A lot of guidelines no longer recommend corticosteroids at all for rebound symptoms because, again, they can just mask the signs and symptoms of anaphylaxis, but you should follow your local guidelines. I just looked at the Uganda clinical guidelines yesterday, and they do still recommend antihistamines and steroids. So just remember that those are not fixing the problem. Those are masking the problem and helping with symptoms. So epinephrine is the treatment. And like I mentioned earlier with our initial case, usually for epinephrine, I would give about 3 doses intramuscularly before realizing I need to move to an infusion. So moving to giving an IV drip of epinephrine for anaphylactic shock. For people who have drug or toxin-induced shock, the treatment's going to kind of differ depending on what we're dealing with. So I know you guys see organophosphate poisoning a lot, and that can lead to like extreme fluid losses as well as distributive shock. And so you're going to have to consider giving fluids and pressors, and then also giving reversal agents. So, give whatever reversal agent for the underlying cause. And then norepinephrine is going to be first line for a lot of these things. Buba just commented that epinephrine is readily available in the Gambia. So thank you for commenting that. I would say if you don't have noradrenaline or norepinephrine, as it's also called, then epinephrine is a great second line agent for a lot of these causes of distributive shock. And Buba, I would say be very hesitant with giving epinephrine for cardiogenic shock if someone's at high risk for heart rhythm problems, but it's always an option. All right. Again, drug or toxin induced, try to give the antidote if you can. I'm trying to think in our setting, something that Nick and I see a lot is overdose of calcium channel blockers or beta blockers. So people will attempt suicide using those medications. And we'll often give them norepinephrine followed by epinephrine, vasopressin. These people will end up on like 4 pressors in addition to getting things sometimes like intralipid, which can be a helpful reversal agent. We give things like high dose insulin and sugar in the IV, so dextrose infusions, glucagon. So there's a lot of things that you can try, but there's not like a reversal agent for calcium channel blockers and beta blockers the way there is for organophosphate toxicity, which is kind of unfortunate. All right, endocrine shocks, thyrotoxicosis. So this is not super common in our setting. I see these once in a blue moon, but they can cause distributive shock. And if you have somebody in this situation, if you think that their super elevated heart rate is what's primarily driving the shock, then you can try giving them a beta blocker, but I probably would not do that while they're hypotensive. So if somebody's blood pressure is 80/40 and their heart rate's 180 or something like that, then I would give the beta blocker to slow the heart rate along with a vasopressor like noradrenaline so that you don't cause worsening of their shock. And then they really need anti-thyroid treatment early. Iodine should not be given earlier than 60 minutes after the anti-thyroid agent. So methimazole or propylthiouracil, and then 1 hour later, you can give the iodine. And they also need IV hydrocortisone because a lot of these people will have concomitant adrenal insufficiency when they have thyrotoxicosis. So usually 100 milligrams of IV hydrocortisone should do the trick, and that will help with their blood pressure as well. Speaking of hydrocortisone, we haven't gone into detail on this, but most guidelines recommend that if you're on at least 2 pressors and you're in something like septic shock, you should probably be adding on hydrocortisone. So that's something we do frequently here is after the second pressor for a septic shock patient, we add hydrocortisone. I'd love to hear in the chat if people are doing that in other settings as well, or if that's primarily where Nick and I work. Coming back to the thyrotoxicosis patient, you can also do external cooling if they have hyperthermia. Keeping people's temperature neutral in all of these cases that we've discussed today is helpful. So if someone has a high fever from septic shock, treat the fever, right? Because if your temperature is, 39 Celsius, then that's going to make your heart rate higher. It's going to increase your work of breathing. You'll be tachypnic. So if you can get their temperature down through something like paracetamol, whether that's oral, rectal, or intravenous, or if you can use external cooling measures like cooling blankets or ice packs, things like that, that can really help reduce their heart rate and reduce their body's efforts and help improve the shock. Derek just commented that they also do hydrocortisone in refractory hypotensive shock or septic shock with suspicion of adrenal insufficiency. So it sounds like the practice where he works is similar to ours. Thanks for commenting on that, Derek. Continuing with endocrine shock, just remember that being severely hyperthyroid can cause cardiac dysfunction. So if you have ultrasound available to you, you can also check to see if there's a cardiogenic shock component, because that may change what you want to order in terms of your vasopressors or inotropes. And if they have normal cardiac output, then we should treat these patients like other distributive shock patients. And again, usually noradrenaline is first line for that. Moving to inflammatory shock. This is also not something we see terribly often, but you can have shock that's distributive from inflammatory causes like pancreatitis or burns. And we're talking massive burns, like large portions of the body that would lead to shock. So fix the underlying cause if you can. So for a pancreatitis patient, you really can't fix that. You just got to give the body time to recover. And for a burns patient, you need to just do supportive care, meaning replace the fluids that they've lost and protect them from losing heat, because they no longer have a shell on the outside of the body to protect them from heat loss. And noradrenaline would still be first line in these patients. Neurogenic shock is another form of distributive shock, and we won't go into large detail, but again, these are usually people with some sort of spinal cord injury, or it can happen from spinal cord tumors or bleeds into the space within the spinal canal, can occur from epidural abscesses. There's a lot of things that can cause this, but this is quite rare. Noradrenaline would still be the first line for these patients. And then obviously they need to have a neurosurgeon involved if you have access to that. Let's move on to hypovolemic shock from severe dehydration. I would love to hear in the chat whether most people are addressing this via an NG tube, giving oral rehydration solution, or whether they're moving to IV fluids right away. I think whether you do one versus the other is going to depend on your access to certain resources. And then we're going to talk about the art and science of reassessment now that we've kind of covered all forms of shock. I'll pause here before we go through reassessment to see if anyone has questions about management of each of the types of shock that we've discussed. Please feel free to chime in the chat or out loud if you have questions. And thank you for everyone who's been commenting in the chat. It's been really active today, which is fantastic. All right, so we'll move to reassessment. We've mentioned capillary refill multiple times, but I think checking this frequently to see whether what you're doing is working is a great plan. Booba just commented in the chat that they move into IV fluids, especially if the patient can't tolerate oral stuff. And I think that's the same as in my setting. And I'm glad you guys have access to IV fluids. I would say if you work at a very rural site or a place where you simply don't have IV supplies, if you have NG tubes, that's great. If you don't have an NG tube and the patient is able to drink and they're protecting their airway, then you can have them start oral rehydration while you get them to a higher level of care. So other key therapeutic endpoints in shock besides capillary refill would be normalization of the vital signs. But I think that's a little bit less important than looking at the patient clinically as a whole, right? So I may stay hypotensive and tachycardic for a while, but if my mental status and capillary refill are improving, then I think I care more about those things. Warm extremities, so people who were initially in cold shock, like obstructive or cardiogenic shock, if their extremities are becoming warm, then that's a good sign that they are increasing their perfusion to the rest of the body. And again, normal mentation. Urine output is one that I think we're not very good at measuring in the emergency department, partly because there's been a big movement here in the United States to stay away from Foley catheters, so staying away from urinary catheterization, because we used to put that in too often and then we were causing a lot of hospital-associated urinary tract infections. But there are other ways to collect urine. So if the patient's awake enough, asking them to just pee in a cup for you so you can measure it. But if someone's truly critically ill, then you can obviously use a urinary catheter. In some settings, you might have access to a condom catheter for men, so something that's external and won't increase their risk of urinary tract infections. I would actually love to hear in the chat how many of you have a condom catheter for female patients. I know we have something similar to that in our setting. It's called a PureWick. It's like, it looks like a little boat that just sits between the legs and it suctions the urine up into a suction cup so that we can measure urine output. And obviously that's less invasive than putting in a catheter. I will say sometimes it misses and doesn't catch everything and patients think it's really gross. So it's not as easy as a condom catheter is for men. But making sure that people are actually peeing is a really important endpoint, especially if you're working in the critical care unit and you have the ability to do this. And finally, improving lactate or base deficit. I know in some of your settings, labs don't come back very quickly. And so that's probably not as helpful as some of these other measures that you can actually, kind of assess at the bedside immediately. Remember that capillary refill is specific, but not sensitive for shock, meaning that it's not going to, delayed capillary refill and responsive capillary refill may not be seen in all patients who are shocky. But if you're somebody who does have delayed capillary refill initially, then reassessing that capillary refill over time as you're receiving interventions like fluids, antibiotics, vasopressors, whatever agent may be helpful. And then fluid responsiveness. I want to touch on this here. And I will preface this with the fact that I am not an ultrasound guru. I use ultrasound daily in my practice, but I do not have the time to sit and calculate cardiac output using an ultrasound machine. And I'm not going to go through this, but this is to let you know that this is a thing, that you actually can assess cardiac output with an ultrasound machine. It requires some fancy math and it does require somewhat advanced skills. When I'm using ultrasound to assess fluid responsiveness, I'm just looking at the squeeze. So it's a little bit less accurate, but I simply do not have time to assess true cardiac output in my setting. But another way to assess fluid responsiveness would be something called passive leg raise. In the chat, if you want to chime in and tell us whether you use this in your setting. So you need to put the person in reverse Trendelenburg. So put them flat and then flip their feet up and hold them there like that for a couple minutes. Obviously, if you have a very obese patient, you may not be able to do this. But for most patients, we can stand there for a couple minutes and chat with them and kind of assess their mental status while we're holding their legs in the air. And then the most accurate way to use passive leg raise is actually looking to see whether their cardiac output improves. And so, like I said, that's a complex measure on ultrasound. I kind of do this the not as accurate way where I just look to see if their blood pressure improves when I hold their legs up. And if it does improve for me, like systolic blood pressure improves 10 to 15 points, then that suggests to me that when I dumped all the fluid from their legs back toward their heart, that they were fluid responsive. So, your legs contain a large volume of fluid. And if you tip those legs up and you bring that fluid back to the heart, and if it increases the blood pressure, then that person person has just gotten an auto bolus of fluid from their legs, and if the blood pressure is going up, that suggests to me they may be fluid responsive, meaning that I can consider giving more IV fluids. A more accurate way than looking at the blood pressure is looking at the pulse pressure, which is just the systolic blood pressure minus the diastolic blood pressure. And that can give you an idea of whether the person, like if that number goes up when you give them an auto bolus by lifting their legs, it can give you an idea if they might respond to fluids. I would love to hear either out loud or in the chat how your institutions are kind of monitoring fluid responsiveness to shock. Are you using mainly capillary refill? Are you using ultrasound to look at cardiac output? Are you using passive leg raise? Oh, Ruth just said IVC on POCUS. Thank you for mentioning that. So the inferior vena cava, often, this is not perfectly accurate. It's not a perfect science, just like with passive leg raise. And so the IVC, if it's dilated and it doesn't move when you're breathing, then that suggests that you are not going to be responsive to fluid. So if it's not moving at all and it's thick and chunky, then it's full of fluid, and giving you more fluids is probably not going to help you. Normally the inferior vena cava, it moves when you breathe, right? So if it's doing that and collapsing all the way, then that might suggest that your volume down, you need more fluid in the tank, or in the pipes rather. And so IVC is certainly a good way to look at things. Pulse volume, Mary, do you mean pulse pressure, or do you mean like how powerful the pulses are, like whether they're weak or bounding? I'd love to hear more on that. Sounds like people are using capillary refill for reassessment.
I think one of the other things to think about too, as you kind of mentioned with the IVC, is sometimes people will use the phrase fluid tolerant, because it's hard to predict based on how the IVC looks as to whether or not their blood pressure will actually improve, but it might have room to trial it, right? So even if it is somewhat collapsible or something like that, they might not improve their blood pressure with a volume bolus, but they tolerate it. And so sometimes when you're in that gray area, that can kind of don't get discouraged necessarily if you give fluids and it doesn't improve your blood pressure, but it'll tell you if you have some wiggle room to try it, versus if it's not, if it's dilated and not variable at all, then it's like maybe I shouldn't try it.
Right. Yeah, I agree with Nick. It seems like in the, okay, thank you, Mary. She's saying like whether pulses are weak or strong. So I think that's another thing to think about, right? So if you started with cold shock and you had very weak peripheral pulses, but now your capillary refill is normalizing and your pulses are stronger, then that's a great assessment of peripheral perfusion. A lot of people mentioned blood pressure and mean arterial pressure. It's not a perfect science, but yes, if their blood pressure is going up in response to the fluids, then hopefully they're fluid responsive. So a few take-home points here. Shock has a high morbidity and mortality, and even more so in low resource settings. And so it's really critical that we diagnose and manage this early. Diagnosis is clinical, so you need to look at the full picture of this person's exposures, their history, what their physical exam looks like. And the treatment should be tailored to the type of shock and the underlying cause. Remember to re-examine your patient frequently. And like I said before, this is going to depend on how critically ill the patient is, what resources you have, how often you're giving interventions. And so you have to determine based on your individual patient how frequently to reassess. But most of these patients, if they're actually coming in shock, they need to be reassessed very frequently. These are my references, and I am going to stop slide sharing so that I can provide you a link to our post participation survey. We would really appreciate if you guys can fill this out for us. Reason being, we try to improve each session to make it better and better for all of you. And so we would love it if you can fill out the survey. Let me try and get that up for you. Please let me know if this link does not work. I'm going to share it in the chat right now. And Nick and I will stay on for about 5 minutes to answer any questions if you have them. This video recording will be posted on our Techies Without Borders YouTube site, and we will also send a written summary of the session in the various group chats. Let's see. Regina just mentioned angiotensin. in cardiogenic shock. We don't have access to angiotensin 2 where I work.
Angiography, please, not angiotensin. Angiocardiography in ischemic heart disease. So you must take care of that.
Yes, thank you. And this comes back to reversing the underlying cause, right? So if you think someone's in cardiogenic shock because they are having an acute MI, they're having acute coronary syndrome, then 100%, Regina, that person needs to go for angiography. They need to go to the cardiac cath lab so that they can get whatever that vessel is that's blocked stented, or they need to be evaluated for a cardiac bypass if they're not a candidate for stenting. Thank you again, guys, for all the comments in the chat. Please fill out the survey, and we will send the link to the YouTube video as well as our summary notes to everybody after the session. Thanks, guys.